Welcome to the 11th Annual PIPC Forum. The Partnership to Improve Patient Care was established in 2008 with an eye toward supporting increased funding for comparative effectiveness research. Why? Because patients and people with disabilities and their providers wanted and needed information that would allow them to make better healthcare decisions. They want to know, what is the best site of service for the care I need? What is the best treatment for me based on my characteristics and priorities? Through the combined efforts of Pixi and so many others, Congress authorized the Patient-Centered Outcomes Research Institute as part of the Affordable Care Act, that most of us know now as PCORI. Over the last 10 years, PCORI has worked toward changing the culture of research to be more patient-centered, by itself requiring robust patient engagement in all of their funded projects. We will hear more from PCORI today about their vision for the next 10 years. The backdrop for PCORI's creation was a strong reaction to academic research that patients and people with disabilities did not find useful, and a long-standing concern with the use of cost-effectiveness analysis being used by payers as a justification for coverage policies that created barriers to needed care based on cost. We just celebrated the 30th anniversary of the Americans with Disabilities Act, a law originally authored by PIPC Chairman Tony Coelho, which made discrimination against people with disabilities illegal. Following that law, in 1992, a state attempted to use cost-effectiveness analysis using a metric called the Quality Adjusted Life Year, or QALY, to determine the services that would be covered in their Medicaid program. A Republican administration determined that the QALY was discriminatory and rejected that Medicaid waiver application. In 2009, as the creation of PCORI was being debated by Congress, Republican senators fought for the new law to include protections for patients and people with disabilities that would prevent Medicare from limiting what providers could prescribe based on a quality-adjusted life year-based cost-effectiveness analysis. They found moderate Democrats agreed with them, and therefore the statute creating PCORI prohibited PCORI from using QALYs and prohibited Medicare from using QALYs. Over the last year, bipartisan opposition to QALYs has grown. President-elect Joe Biden made a statement early in his campaign that he would ensure people with disabilities are not denied coverage based on the use of the quality-adjusted life year and related enterprises in making coverage and payment determinations in public programs, noting his support for its prohibition in Medicare. The DNC platform states that Democrats will ensure that people with disabilities are never denied coverage based on the use of quality-adjusted life year indexes, and commits to ensuring non-discrimination and access to health care, building on the protections for people with disabilities that are enshrined in the Affordable Care Act. Notable progressive Democratic senators like Senator Elizabeth Warren, in a letter to the Office for Civil Rights opposing COVID-19 discrimination against people with disabilities, recognized that traditionally, American healthcare policy and treatment approaches have largely been driven by the concepts of cost-effectiveness analysis and quality-adjusted life years. But these approaches are inherently discriminatory. They devalue the life of people with disabilities and older adults. Yet, over the last few years, there is a renewed debate about the use of QALYs due to the emergence of an entity called the Institute for Clinical and Economic Review, also known as ICER. It's an entity largely funded by Arnold Ventures that not only uses the QALY, but calls it the gold standard. Despite the long history against use of QALYs in the United States, they have touted themselves as a credible arbiter of treatment value for payers, despite significant criticism from the patient and disability communities. ICER has garnered support from both private payers and state Medicaid programs. In 2018, PIPC Chairman Tony Coelho led the fight against the use of QALYs as a benchmark for coverage when it was proposed by the pharmacy benefit manager CVS Caremark. Thankfully, CVS Caremark stopped marketing that option to new clients as a result of opposition from patients and people with disabilities. State Medicaid programs have also notably attempted to use ICER's assessments to manage their formularies. We spoke to the executive director of the Massachusetts Disability Policy Consortium about their concerns.
It's about the fundamental logic, and the fundamental logic of the quality-adjusted life year is that the lives of people with disabilities are inherently less valuable and inherently less worth saving than the lives of people who do not have disabilities. Because the heart of the QALY is what's known as a disability weight. And what that is it's a number between 0 and 1. It's a decimal, but you can think of it as a percentage, right? And that is the percent or the share of a normal life that the life of someone with a particular disability is worth. So you'll take a disability and you'll assign a particular weight to it. Maybe it's 0.75, right? That means that according to the QALY, the life of someone with that disability is worth 75% as much as the life of someone with no disability at all. So that is QALY logic. And the thing is, before the pandemic, advocates like me, I've been fighting for years against the use of metrics like this. My organization, Disability Policy Consortium, we're a state-level civil rights advocacy and research organization run almost entirely by people with disabilities, myself included. We were told that we were crazy. We were told, oh no one would ever use the metrics that way. No one would ever actually say that people with disabilities are less worthy of treatment. People with disabilities should go to the back of the line for treatment. This is purely exists as a negotiating tactic, as a tool to try to bring drug prices down. And to be clear, we support bringing drug prices down. We have fought the drug companies in Massachusetts. We have been part of the coalition fighting for legislation that would bring drug prices under control, because the bill that we were fighting for did it without discriminating against people with disabilities. But we were told when we brought this issue with policymakers, that metric would never be used that way. And then the pandemic happened. And in state after state after state, well, they didn't use the QALY explicitly, they used the logic of the QALY. They used the belief that when you are choosing which lives to save, the lives of people with disabilities are less valuable. In states like Alabama, this manifested in their state crisis standards of care, the document that says when people come into the hospital with COVID and there aren't enough ventilators to go around, who gets one and who doesn't, where they said people with intellectual disabilities should not get treatment at all. We tried to get the QALY banned here in Massachusetts. We didn't get that far yet. Here, legislative leadership wrote their own bill related to pharmacy, and it was pushed through in a matter of a couple of weeks with no hearings, very little debate. And by no means wholly a bad bill. I think it took a reasonable approach by and large. Is that it essentially what it did is it empowered the Health Policy Commission here, which is a state entity, independent state agency, focused on the cost of healthcare, principally on containing the cost of healthcare, but that has heretofore done next to nothing regarding pharmaceuticals. It's been looking at things like hospital billing practices, for example. And it empowered them to analyze the price of drugs, to make determinations on whether or not prices were fair and reasonable, to propose what they believe a fair price would be. And it created new options in how Mass Health could negotiate with drug companies and how the Health Policy Commission could get involved in that, how drug companies could be referred to them for these analyses. But as originally written, there was really nothing in the legislation about what kind of metrics could be used, about how people with disabilities or patients would be involved in this process. It was really sort of largely left up in the air how this determination would be made. And that really concerned our community because of all these issues with the QALY that we laid out. And so we had an amendment introduced. This amendment did not mention the quality adjusted life year at all. It was simply, essentially took that same language from the coalition bill, the one that said that Massachusetts state agencies in doing this work could not use any metric which valued the lives of people with disabilities less than the lives of people who did not have disabilities. And now we come to the role of ICER, the Institute for Clinical and Economic Review, based here in Massachusetts, heavily involved in this issue all around the world, and I would say the chief proponents of the use of the quality adjusted life year. They consistently make the case that you have to use qualities. Their position, though now perhaps as the immoral, discriminatory nature of the quality is becoming apparent, they seem like they may be trying to pivot, but their position for a long time has been that if you don't use the quality, you cannot get affordable prescription drugs. And despite the fact that this amendment didn't mention the quality, it just forbade discrimination against people with disabilities, they lobbied against our amendment and ultimately succeeded in killing it. But we didn't get nothing. We got vital information put into legislation regarding transparency that said that if analyses performed by third parties, like ICER, were used in the process of determining whether a prescription drug was cost effective, that it would have to be disclosed what analyses were used and what methods, like the quality they were based on, and what impact they would have on subgroups, like, for instance, people with disabilities. And that is vital because it creates the ground upon which we can argue, upon which we can fight determinations that negatively impact people with disabilities. But it was not by itself sufficient. And so since this legislation passed, we have been consistently engaging with the Health Policy Commission here in Massachusetts, trying to make the case that you do not need the quality to do these analyses, and that the disability community needs to be fully included in this process, not merely consulted and given some lines in a write-up, but that unlike ICER's process, which pays lip service to our community, but provides no channel whatsoever, whereby our input can meaningfully impact the recommendations, that this process needed to actually allow people with disabilities a voice in influencing the outcome. So that discussion is still going on. We've had some really encouraging signs, some really positive meetings between folks at the Health Policy Commission and experts like Dr. Jaime Caro, who designed the efficiency frontier system that is used by the German government that produces high quality, evidence-based determinations of whether drugs provide good value without discriminating against people with disabilities. And we've pressed for our community to be involved, and we've made the case again and again and again that the quality is inherently discriminatory. And we've gotten Mass Health to make some commitments. They've told us that they are interested in alternatives to the quality, that where they feel that there are good alternatives to the quality, they will use them instead. So we are opening that door and we are pressing for it, and we're going to keep pressing for alternatives to the quality that actually value the lives of people with disabilities. But there have also been concerns. In the past few months, the Health Policy Commission announced technical assistance arrangements, both with ICER and with Portal, another academic entity that are significant supporters of the quality.
Gunnar Esiason, who lives with cystic fibrosis, talks to us about New York and other states.
The newest weapon in the United States being used against patients is called the Quality Adjusted Life Year, or QALY. It's a showy name for a mathematical model that seeks to determine the value of a disabled life while threatening the very thing patients living with unmet medical needs rely on: breakthrough science. Its proponents say it could help control drug prices, but they overlook that it has been used by governments around the world to deny coverage for medications based on their cost. A bureaucrat should not be allowed to tell me how much my life is worth because I was born with a rare childhood disease. The thing is, that childhood disease called cystic fibrosis did not kill me. Instead, I'm alive and healthy. One of the most fundamental flaws of QALY is that it is used subjectively, which then begs the question, who is doing these analyses? In the United States, a self-proclaimed watchdog called the Institute for Clinical and Economic Review, or ICER, is driving the train under the flag of reform. ICER's analyses have been an instrument of the drug pricing war that holds patients and families hostage. It forces us to ask the question, will our insurance cover our medications? The cornerstone of the calculation is disability weight adjustment to predict when a patient might die. From ICER's perspective, it is not if cystic fibrosis kills a person born with CF, but rather when. The when is important because it determines when my payer stops accruing medical expenses. To account for that, modelers apply a utility function to a patient's life to illustrate his or her health. The utility is then multiplied by the expected number of years of life a patient has left to live to yield the additional qualities recovered by a drug. The scale ICER uses in its cystic fibrosis reports is based on pulmonary function. It maintains that the highest utility a person with CF can achieve is 0.92. Perfect health would otherwise be assigned a 1. The implicit meaning here is that a person living with cystic fibrosis can never achieve full health even with medical intervention. Applying the scale to my own life, I made the journey from a health utility of 0.92 when I was at my healthiest, all the way down to 0.692. The slide started when I suffered my first massive hemoptysis, or coughing up blood. It happened on the football field during a conditioning session in high school. I collapsed and then came to the sight of dozens of concerned teenagers, my teammates, huddled around me as if they had all seen a ghost covered in blood. Coughing up blood is much more than Hollywood romanticizes it to be. It tastes like iron, then smells like it too when it starts to seep up into the sinus cavity. The telltale sign hemoptysis is coming on is a strange gurgle. Imagine a rattle coming from deep inside your chest. The body's natural reaction to it is to force as much of the blood out as it can with a deep, watery cough to make room for the exchange of fresh oxygen. The crescendo is when the blood is pushed out of the airways until it bursts into a cascade of red syrup. Its consistency is not unlike the maple syrup I like to put on my waffle in the morning. Now I'm at a health utility of 0.801 after a drug called Trikafta intervened. Those bouts of massive hemoptysis, long hospital stays, and everything in between are all distant memories. But somehow, I'm supposed to believe the decade I spent crawling out of critical illness is supposed to be captured in a few arbitrarily calculated numbers. I call that conjecture. The calculation is an attempt to normalize disease severity with the efficacy of varying medications and their costs across the health system. The results are supposed to aid in coverage decisions to show which medications recover the most qualities and therefore should be covered. New York State Medicaid is one such example of a payer citing ICER's analysis of cystic fibrosis drugs. The problem with using ICER's model is twofold. First, the health utility scale used to determine qualities very clearly assigns a lesser value to a person living with a terminal illness compared with a condition that could be cured. The National Council on Disabilities says, quote, they create an environment of systemic inequality where people with disabilities and chronic conditions that will be managed rather than cured are less likely to receive access to treatment under health systems that ration care utilizing quality. Quality, of course, assumes rationed care. Quality calculations maintain that I can never truly be considered healthy when compared with people who can be cured of their health issues. Since the disability weighting is part of the multiplier, any benefit from a medication applied to my life will not be compared equally to a drug that cures someone else's health condition, because at the end of the day, I will still live with cystic fibrosis. With that inequality in mind, the National Council of Disabilities says QALY is a violation of the Americans with Disabilities Act when being used to determine coverage. The second flaw in the model is that it relies on applying Trikafta's cost over a patient's expected lifetime, wherein the model forces an unfair trade-off on people with terminal illness. It says that as I recovered from critical lung disease, I became more expensive to take care of because I did not die younger. It misses the whole goal of medical care, to keep people alive. The $311,000 annual listed price tag attached to Trikafta is huge, but it won't always be huge, even though ICER assumes it will. In that assumption, ICER misses one of the most important nuances of drug development. Newly branded medications are patent protected so that the drug developers can recoup the cost of developing it before making a profit. Those profits, however, don't last forever because the patents on branded drugs expire, at which point other drug makers are allowed to flood the market with near carbon copies, forcing the price down. ICER curiously does not input genericization into their models. Somehow, it's okay that I am penalized for getting older, but it assumes drugs and their prices do not age. The reality is they do. 90% of all drugs prescribed in the United States are generic, which costs little more than the price to produce them. Those generics were, at one point in their respective histories, branded. ICER even admits to omitting a genericization. Quote, estimating such changes may be especially difficult in the US market where drug prices are mostly unregulated and changes in prices occur relatively frequently. Oh, the irony. ICER says I will incur difficulty later in my own life because I'm disabled by way of applying a less than perfect utility value besides my symptoms, but they maintain that the math might be just a little too hard for them to overcome on the same time horizon. Payers truly capture unquantifiable value in generics. Patients they are covering reap the same health benefits, which broadly include lesser healthcare utilization, all for a significantly lower cost. The cystic fibrosis patients of tomorrow and generic versions of the miracle drug that I take today will be cheaper to care for because they will not suffer the same consequences of rapidly progressing illness that I live through, and they will no longer have to shoulder the burden of development cost of a drug since it will have already been paid off. Despite these two crucial flaws in quality calculations, ICER maintains that Trikafta's price is too high relative to its clinical benefits. One must look no further than the dysfunction in the antibiotic market to understand how disincentivized markets can truly cause harm. I understand the irony in my call for a shift to long-term thinking. I'm living with a terminal illness. ICER knows it, and I know it. But the difference between me and ICER is that I possess the power to look ahead, while bureaucrats do not. Instead of relying on bad math, policymakers should focus on the long-term consequences of putting up more barriers in front of patient care. We need to sever out-of-pocket costs from the healthcare system, embrace genericization, and value disabled lives equally now and forever. Thank you.
Thankfully, we are also seeing progress from some states in recognizing that ICER and the QALY is not the appropriate way to move forward. In Oklahoma, where ICER studies were being used by their Drug Utilization Review Board to impose restrictive utilization management strategies for certain treatments, the state legislature responded by passing their own prohibition on the use of QALYs. Disability groups applauded Oklahoma's leadership. Recently, PIPC Steering Committee member Maria Town had the opportunity to interview staff at the National Council on Disability regarding their opposition to the use of QALYs by policymakers, including opposition to their importation from other countries. Maria also interviewed Kelly Buckland, Executive Director of the National Council on Independent Living, regarding a resolution against the use of QALYs led by the Autistic Self-Advocacy Network and Not Dead Yet.
What it says is, therefore it be resolved that NICL opposes the use of the QALY in all decisions concerning healthcare coverage. And to be it further resolved that NICL will provide technical assistance to CILs, which are Centers for Independent Living, to raise awareness that the use of QALYs in healthcare coverage decisions is discriminatory and will encourage and advise local and state efforts to ban the use of QALYs, and be it further resolved that NICL will work with Congress, the Department of Health and Human Services, the Office of Civil Rights, Department of Justice, and other relevant state and local agencies to educate stakeholders and ensure that QALYs are not used in decisions concerning public and private healthcare coverage. And as I mentioned, this resolution was passed unanimously by the NICL membership.
Well, Kelly, thank you so much for that description, and thanks to the entire NICL membership for their decisive action on this issue.
Even more recently, the National Minority Quality Forum presented information about the implications of QALYs for exacerbating health inequities, highlighting the patient experience of Dr. Lakia Bailey, a sickle cell patient and director of the Sickle Cell Community Consortium, about her experience with an ICER assessment of sickle cell treatments.
Sickle cell disease was identified over 100 years ago. It is the first disease to have its molecular basis known. We lost so many champions and advocates along the way. And finally, 2019 came around. There has been an attempt with these QALYs, which has already been pointed out, have major bipartisan opposition because, and I'm going to be very, very transparent here, they are at their heart discriminatory. When you're discussing the value of therapy, we are discussing how much is this woman worth.
Today, we want to talk about how we can do better. That is why PCORI was created by Congress. We want to talk about the invaluable role entities such as PCORI can play in ensuring affordable access to the healthcare that is the best for the person. It isn't enough to view people as averages, not in this age of personalized and precision medicine. PCORI has a new mandate to collect data that may be economic without using a cost-effectiveness metric such as QALYs. We have shared as part of background materials for our discussion today our new report looking at patient-centered cost outcomes. We know that treatment benefits and harms are major factors driving patients' choices. However, the complex relationship between economic impacts and cost outcomes, benefits, and harms needs to be studied further to establish how patient preferences contribute to treatment decisions and treatment adherence. We are excited to hear from PCORI's new Executive Director, Dr. Nikayla Cook, about how they are planning to implement their new mandate to collect and disseminate information on cost and economic considerations in a manner that recognizes the importance and complexity of using patient preferences to drive research.
Good afternoon. I'm Nikayla Cook, Executive Director of the Patient-Centered Outcomes Research Institute, also known as PCORI. On behalf of the entire PCORI team, I am grateful to the organizers of Pixi for hosting this forum and for the kind invitation to participate. While many of you may be familiar with our organization, a quick refresher on our mission and work will help set the stage. PCORI was created 10 years ago with an inspiring mission of helping people make informed healthcare decisions and improving healthcare delivery and outcomes. We do this by funding patient-centered research and its implementation, guided by patients, caregivers, clinicians, and the broader healthcare community. During our first decade, PCORI built a strong portfolio of research, moved results into practice, and engaged many individuals and organizations in our work. 1 year ago this week, we achieved a significant milestone when Congress reauthorized our funding for another 10 years. That achievement was made possible by the support from Pixi and so many others. We truly appreciate your help and continued support and partnership. Reauthorization gave PCORI and the healthcare community we serve a remarkable opportunity to fund critical research to inform a more effective, efficient, and patient-centered healthcare system. It also means we can fund implementation projects for a growing number of research findings to promote more rapid uptake of evidence into clinical care settings. Further, reauthorization allows us to continue building communities ready to engage in and advance patient-centered research, from identifying the questions we ask in study design to the dissemination and implementation of results. In short, we can build on the successes of prior years and continue to fulfill our mission. Reauthorization also brought 2 new research priority areas for PCORI to address: strategies for improving maternal morbidity and mortality, and improving health for individuals with intellectual and/or developmental disabilities. These issues are of critical importance to PCORI given the long-standing health challenges faced by those affected. And we believe our research done differently approach will contribute to meaningful health improvements. We are committed to an inclusive approach to funding research that will address these 2 topics over the next decade. Since our founding, we have already invested $42 million in research on intellectual and/or developmental disabilities and $60 million in research on maternal health. In September, we opened a funding opportunity that offers $30 million for research in these new priority areas. We will begin reviewing proposals when the application period ends next month. We've invested another $4 million in engagement projects for those living with disabilities and $4 million in engagement awards on maternal morbidity and mortality. These efforts seek to increase the meaningful engagement of patients, caregivers, clinicians, and other healthcare stakeholders in our research. Engagement projects accomplish this in 3 ways: by expanding the knowledge and skills of participants, by creating ways to build connections and share research findings, and by supporting patient-centered outcomes research convenings. Our reauthorizing legislation included a provision designed to ensure that our work will be even more relevant and useful to our stakeholders. It allows us to consider the full range of clinical and patient-centered outcomes that meet the needs of patients, clinicians, purchasers, and policymakers. This includes, as appropriate, capturing the potential burdens and economic impacts of various healthcare services, along with the relative health and patient-reported outcomes and clinical effectiveness measures our work has captured to date. While this authority expands the types of data that can be considered in PCORI-funded research, the reauthorizing legislation did not remove the statutory prohibitions on funding cost-effectiveness analyses or establishing a cost per quality-adjusted life year threshold. In addition, PCORI is still restricted from developing clinical guidelines or recommending coverage decisions. But by capturing a more robust set of data from the research that PCORI funds, patients, people with disabilities, caregivers, clinicians, policymakers, and the broad healthcare community will have more information and tools to make better informed decisions about healthcare. PCORI understands that discussions of healthcare cost burdens and economic impacts have several diverse perspectives that we and others must consider and balance. And we embrace our role in informing this discussion as the nation's premier funder of comparative clinical effectiveness research and patient-centered outcomes research. Therefore, we're pursuing a transparent and deliberate approach to its implementation. In September, we released for public comment several proposed principles to serve as a framework for how PCORI is interpreting this new authority. The comment period ended earlier this month, and I want to thank Pixi for providing thoughtful input and feedback on the proposed principles. We also held 2 webinars in October that included patients, caregivers, consumers, disability rights advocates, and other stakeholders. Those webinars are archived and can be found on our website at www.pcori.org. And now that the public comment period has closed, PCORI is analyzing the feedback we received through the webinars, public comment letters, and the many discussions we've had with stakeholders, including patients and people with disabilities. We received a wide breadth of thoughtful and detailed comments. The public comments provided constructive input in support of the draft principles and PCORI's new authority to consider cost and economic data. We also heard that PCORI is uniquely positioned to take a patient-centered and holistic approach to the consideration of costs, helping to identify or standardize measurement of costs that are important to patients and people with disability, particularly out-of-pocket costs and non-medical costs. Comments also focused on the importance of cost burdens and impacts from a societal and community level. And many emphasize that it's critical that patients and their caregivers be engaged in the process to identify the cost and economic outcomes that are truly relevant to them. Our team is now in the process of developing guidance for future applicants, and we'll be updating the principles based on the input we've received. Our goal is to have updated principles approved by our board by next spring of next year. In addition, PCORI's methodology committee will be undertaking work to update PCORI's methods and standards, which will shape how PCORI research is conducted. I look forward to continued dialogue with Pixi as this process moves forward. With a decade of accomplishment behind us and a 10-year reauthorization sustaining us, now is the time to envision a bold future for PCORI, We are using a multi-pronged collaborative approach to develop our strategic plan, which includes PCORI's national priorities and research agenda. These documents articulate a framework to guide PCORI's funding while reflecting the input of our stakeholders and our congressional mandates. We are conceiving PCORI's next phase starting with 3 key elements: evidence generation, stakeholder participation, and our pillars of engagement, innovation, and doing things differently. PCORI continues to generate evidence that is relevant to patients, clinicians, caregivers, and the broader health community. We are engaging stakeholders and welcoming input in developing our national priorities and research agenda as part of our strategic plan. We are building on our pillars of engagement, innovation, and doing things differently. We're developing new partnerships and welcoming new voices while sustaining existing relationships. We're seeking diverse advice in priority setting and topic selection. And we're working to achieve demonstrable impact with patients, caregivers, clinicians, and others as partners for dissemination and uptake of research results, while maintaining PCORI's standing at the vanguard of comparative clinical effectiveness research and an integral component of the research ecosystem in the United States. We are innovating to advance rapid cycles of evidence to implementation and pragmatic approaches to reduce health disparities. And with this, we have the potential for impacts that include near real-time implementation of research findings, uptake into clinical care guidelines, and reduced variations in care. Our goal is to integrate research with clinical care to create what we call learning healthcare. This approach asks questions that are relevant to patients in the broader healthcare community and guides comparative clinical effectiveness research and implementation science that speed results to patients, thus quickening the pace from evidence to practice. As we work to achieve our future vision, PCORI's mission remains our North Star. We continue to provide patients, caregivers, clinicians, and others with information they can use to make decisions that reflect their desired health outcomes. I would like to introduce you to one of those patients, Robert Smythe. He was a lead community coordinator for a PCORI Engagement Award that built a stakeholder network to identify priorities for research addressing barriers to community participation for people with intellectual and developmental disabilities. Robert is also a renowned puppeteer and accomplished actor who has worked hard to be understood throughout his life. While some people said he expressed himself eloquently, others couldn't understand what he thought was very clear. At age 50, Robert finally learned why. He has autism. Shortly thereafter, he learned about the PCORI-funded engagement project and quickly embraced his new research role. He said this about his experience: intellectual and developmental disabilities are very complicated. For most of the people who are actively involved in looking for solutions and help, they have a very small window of time that they are operating in, because every year that they wait, they or their child is not getting help. It's going to require lots of different solutions. What's really terrific about this is that it gives people choices and the opportunity to choose the option that suits them. PCORI believes that patient-centered care begins with knowing and involving patients like Robert in our work, listening to patients and understanding what matters to patients, their caregivers, and their families. I know you, your members, and many patient organizations attending this forum share the goal of making our healthcare system more patient-centered. We at PCORI share that same goal. We thank you for your ongoing partnership and commitment, and all of us at PCORI look forward to continuing our work together.
Before we go into a live discussion with our panel, we will hear from PIPC Chairman Tony Quella.
Thanks to every one of you who've joined us today for the 11th Annual PIPC Forum. Before we hear from our live panel, I wanted to share with you why PIPC's work is so important to me personally. When I was a teenager, I hit my head on our family's dairy farm. A year later, I started having passing out episodes. My very Catholic Portuguese parents did not share with me that doctors thought I had epilepsy. For them, the Catholic Church taught that seizures were a sign of being possessed by the devil. Instead, they took me to witch doctors. until I finally refused to go to any more. I was a good student, later attending Loyola Marymount University in Los Angeles. And after graduation, I decided I wanted to be a Catholic priest. I got a physical and was given the news for the first time that I had epilepsy. This is when I was 21. While I was excited to have a diagnosis, it meant I could not be a priest. And it meant that I had to list my diagnosis on my job applications. I never got an interview, and my family said, "No son of ours has epilepsy." I was in despair, started drinking too much, and became suicidal. At that time, the stigma of epilepsy cost me my family, my faith, and my career. With the help of a mentor, Bob Hope, I was given the advice that I didn't have to practice my ministry in a church. I could also practice it in politics. So I changed my goals, and I got a job with my local congressman. When I ran for his seat, my opponent asked my constituents what would happen if I had a seizure visiting the White House. I replied that I'd seen many members of Congress have fits at the White House, and at least I would have an excuse. I knew exactly what to do first. I put my energy into authoring the Americans with Disabilities Act. And after it passed, I've spent my life advocating for its enforcement. In 2008, Senator Ted Kennedy, a good friend, asked me to chair a new coalition called the Partnership to Improve Patient Care, PIPC. He knew my story, and he was counting on me to make sure that the coalition embodied the mantra of disability rights movement. Nothing about us without us. The coalition rose from frustration that research often didn't include patients in the process, and therefore often asked questions that weren't necessarily relevant for how we made decisions. We fought for the creation of PCORI. We fought for PCORI to put patients and people with disabilities at the center of the research process. We fought for the statute to protect us against being deemed too costly to treat. No one wants to advance affordability in healthcare more than the patients and people with disabilities that rely most on our health system. But here in the United States, we have laws that protect us from discrimination and from policies that would undermine our access to healthcare. It is those very laws that have protected us during COVID-19 from state policies that would otherwise have put us at the back of the line for a ventilator and a health shortage. Today, you have heard much about quality-adjusted life years, QALYs, a metric that inherently discriminates against people with disabilities and chronic conditions by devaluing our lives. You've also heard from PCORI's new executive director, Dr. Michaela Cook, about how their funded research is different. In the disability community, PCORI's emphasis on studying disability, and particularly intellectual and development disabilities, is unique. The burden and impact of healthcare services on patients and people with disabilities is not limited to what we call the medical model, which only focuses on healthcare system costs. In the real world, patients and people with disabilities are grappling with caregiver needs, transportation challenges, the ability to work, and other impacts that are seldom captured in research. With this kind of holistic information, we can make truly informed health decisions. And policymakers and payers can better understand how their decisions impact our quality of life. I want to emphasize, as Dr. Cook did, that PCORI's statute puts a strong emphasis on assuring that research looks at subpopulations, providing an opportunity to focus on issues such as social determinants of health outside the health system. On our live panel today, you will hear about the work we did in partnership with National Minority Quality Forum to understand how current value assessment frameworks using quality-adjusted life years exacerbate health inequalities. We are excited that PCORI's collaborative approach gives all of us an opportunity to be part of their work to improve how people make health decisions. And I truly believe that PCORI's work is essential to driving down costs by assuring people are able to make individualized care decisions that meet their needs, thereby preventing adverse events that lead to more acute health challenges. I hope that all of you watching today will learn more about PCORI and engage with us at Pixi to be part of the solution to our health system's challenges. We can advance reforms to our health system that do not entrench the stigma that our lives are less valuable. I want to thank all of those that contributed to our discussion today for sharing your stories. I will now turn it over to our live panel.
We'll give everybody just a moment to turn on their cameras for our live panel and to get off of mute. Thank you. I hope that was, it's always awkward to see yourself in a pre-recorded video. It's a first for me. Thanks to everybody who's joined us today. So I'll go ahead and just get started while everybody jumps in. There's a long history of concern about the discriminatory impact of quality adjusted life years and their reference by policymakers in the context of healthcare policies. And while we often hear about quality-based cost effectiveness in the context of prescription drugs, we know that valuing health this way has historically had implications for how services are covered more broadly too. There seems to be bipartisan agreement against quality-based cost effectiveness, whether by reference to entities such as ICER or by reference to countries that rely on them, and support for entities like PCORI that have demonstrated the power of being patient-centered. Our panel will share with us more personally how they hope to see policymakers address health and reimbursement and coverage policies in ways that don't implicate discrimination. So I'm going to go ahead and introduce our panel today and start with a few questions. There is at the bottom of your screen, you'll see a Q&A box. If you do have a question and we have time at the end, we will go through the Q&A box for questions to throw out to the panel. So feel free to do that as we talk. So to start with introductions, we first have Dr. Gary Puckrin, who is the President and Chief Executive Officer of the National Minority Quality Forum, formerly the National Minority Health Month Foundation, a not-for-profit organization that he founded in 1998. The forum addresses the critical need for strengthening national and local efforts to use evidence-based, data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. And as Tony mentioned, you can learn more about his insights in a paper that we jointly drafted called Traditional Value Assessment Methods Fail Communities of Color and Exacerbate Health Inequities. Thank you, Dr. Puckrin, for being here.
Glad to be with you.
And next we have Andrew Sperling, who is the Director of Legislative and Policy Advocacy at NAMI. In this role, he oversees NAMI's federal policy agenda in Congress and before federal agencies. Andrew is also on Pipsi's steering committee and has been a tremendous resource to us on Pipsi's all of our work, and in particular, the need for patient-centered research and policies. He has also had a front seat to quality-based cost effectiveness analyses that are conducted by groups like ICER for mental health treatments. Next, I have Rachel Patterson, who is the Senior Director of Government Relations and Advocacy for the Epilepsy Foundation and is also a Pipsi Steering Committee member. She currently co-chairs the Health Task Force of the Consortium for Citizens with Disabilities, whose members represent the disability community more broadly. We are excited to hear more from Rachel today about CCD's vision for next year. And I think we may have joining us shortly Kelly Buckland, who is the Executive Director of the National Council on Independent Living, and you saw a little bit of his clip during the pre-recorded video. Kelly was at the table early in PCORI's implementation, helping them hone in on how to appropriately ensure their work reflected the priorities of people with disabilities and the disparities in care that they face.
Sarah, this is Kelly. I'm here.
Oh, great. Thanks, Kelly. So we're going to dive into some questions now for our panel. And Dr. Puckrin, if you don't mind, I'm going to start with you. During the process of ICER conducting the value of assessing the new value of sickle cell treatments, the flaws of their methodology for communities of color were made obvious. We talked a little bit about this in the paper that we jointly drafted, and I wanted to give you an opportunity to talk about that.
Thank you so much, Sarah. You know, the National Minority Quality Forum, our work has really been around collecting health data. We've been collecting that for about 20 years now. We've built a database of over 5 billion patient records, and we continue to collect data on about 160 million lives per year. And in looking at all of that data, what we've come down with and understand is the principal purpose of our healthcare system is to reduce patient risk. No patient comes into the healthcare system expecting that their risk is going to be elevated for hospitalization, emergency room visit, mortality, disability, and the system is there to improve the quality of their life. And the challenge with ICER and the work that it does is that it's really prioritizing financial risk. It is a system that, and they don't talk a lot about the patient risk and the obligation of the healthcare system to make sure that every patient who comes through the door gets fair quality. And so, you know, when we look at ICER, we've decided that it's not even worth getting into an argument with them because we see the world so fundamentally different. And the idea of reducing patient risk is extraordinarily important, and even more importantly, it needs to inform how we build our healthcare system. Right now, our healthcare system is really focused on financial risk. It goes well beyond ICER. If you look at the Medicaid program, right, it's all about managing financial risk because the state governments have to balance their budgets every year. Even in the Medicare program, financial risk. If you look at the employer-based system, it's all financial risk. And the challenge is that it slows up innovation, it slows up our ability to really find cures. We are really amazing. If you think of what's happened right now with the virus, in 8 months, we've got a vaccine. You know, no generation before us had that capability. And when I think of ICER, I think of Luddites. I think of people who are lost in the past somewhere, thinking that they're doing good to the society, when really we need to have a healthcare system that is supporting our biology, that when everyone comes into the healthcare system, no matter race, ethnicity, gender, disability, it's all the same. We want to reduce their risk. And anything short of that is a disparity, and even more important, is a social determinant of health, and needs to be reported as such. And that's the way as we looked at, took a deeper dive into the world of ICER, we recognized that this was an organization that time had passed by, and only people living in the legacy system really want to support it.
That's a very powerful statement. I appreciate your comment about calling it a legacy system. I hadn't thought of it that way. That's really interesting. So Andrew Sperling, I'm going to go to you next. You were a staunch advocate of Picori's statute to bar the use of QALYs early on. Can you tell us a little bit about your personal experience going through value assessments for mental health, and some of your concerns about how that translates then into actual decision making? Whether, I think about it primarily in the context of what if we were to use those kinds of value assessments in public programs, what would the implications potentially be?
Well, first of all, thanks for having me. I'm proud to have been a part of PIPC even going back more than a decade. And I want to remind everybody, back in 2009 and 2010, this was not a slam dunk to get these guardrails put on Picori to make sure they weren't doing cost effectiveness research, and that their findings didn't result in coverage decisions by government programs such as Medicare and Medicaid and the VA. That was what was in the House bill the House passed Affordable Care Act. It would have been an entity owned by the government, very, very different than the structure we have now with PCORI, with the independent board, with requirements for diversity, representing employers, health plans, patients and their advocates, and industry. It would have been a completely government-controlled entity, very similar to what happens in the United Kingdom with the NICE organization, where they are using explicitly cost-effectiveness research to drive government coverage policy for their national healthcare system. And we only have to look just across the ocean to see what happens in the United Kingdom in terms of sometimes innovative treatments not being covered at all, or being covered 2 to 3 years after they've been approved by our Food and Drug Administration. And even when they're approved, with certain protocols and restrictions barring physicians from prescribing those therapies unless patients meet certain criteria, including expected life expectancy. And so that's where we run into real trouble. We at NAMI, the National Alliance on Mental Illness, have had some experience with ICER reviewing treatments for psychiatric disorders, and something actually it's not a psychiatric disorder. It's something called tardive dyskinesia. I won't go into all the details of what that is. It's a neurological condition, and people with schizophrenia that took the older neuroleptic medications to treat psychotic disorders have this. It's facial tics. It's involuntary muscle spasms, twitches. It's a very difficult disorder to live with. And a few years ago, 2016, we got our first breakthrough therapies, 2 of them to effectively treat this disorder. And the ICER report really, I would say, compounded that stigma. These medications do not extend life expectancy beyond a day. So it's not about extended life expectancy, but they really can. It's a game changer for someone that's living with this disorder, particularly with a facial tic. You can't work in retail. You run across people, and you know the value of not having to live with a facial tic in terms of how it affects your daily life is immeasurable. And I'll just give you one bizarre example of what they did. One of the sponsors of one of these medications actually did before and after videos of patients that were enrolled in the trial. And ICER refused to let the sponsors show those videos at their sort of sham public hearings that they held on this report. So, to really hear directly from patients, they didn't want any of that testimony. They didn't want people to talk about how living without a facial tic really dramatically changed their lives and made it better. So real frustrations there, and we need to continue to support PCORI, but make sure it does its work the right way, that it really informs clinical decisions, recognizes homogeneity and the diversity of patient populations, and moves us toward personalized medicine and precision medicine.
Thank you, Andrew. That's very helpful. So Rachel, I know that you also follow these issues closely in your work, both with Epilepsy Foundation and CCD. We talked a little bit in the recorded part of the discussion about the National Council on Disability report, which I will point out was a very long 70+ page report about the dangers of the quality adjusted life year. And I was hoping, Rachel, you might be able to give us a little more information both about the NCD report and about CCD's positions.
Sure. So for a little background, the National Council on Disability is an independent federal agency, and they're tasked with providing information and recommendations and expertise to Congress and the administration when they make policy. And they did their report on QALYs as part of actually a larger report on bioethics and disability. They got into issues like discrimination in organ transplantation, ideas of medical futility, and they finished this in late 2019. But they pointed out a lot of issues that we have seen play out in this pandemic, just like Colin pointed out. Those crisis standards of care that say it's okay to not treat someone with a disability if your hospital at capacity. It's all based, again, on this fundamental idea that life with a disability is less worth living. And that's the same idea that underlies the quality adjusted life year. So they came out with this report out of this larger effort. And what they found is that it's discriminatory. It puts a lower value on the life of a person with a disability. I have to say, there's a lot. You can read a lot of papers about the quality and how great it is, and there's lots of math and there's lots of economics. And our position is not about that, although we have thoughts about that too. It's the very idea that goes into it before you start building any economic models. So what NCD recommended is, because they make these recommendations, was that Congress avoid any policy related to health coverage and pass a ban on the use of QALYs. We have one in Medicare. I think it would be great to pass one in Medicaid or, addressing other health programs. They recommended that the Department of Justice and the Department of Health and Human Services Office for Civil Rights issue guidance saying that the ADA applies to state programs like Medicaid, and that would apply to the Americans with Disabilities Act applies, and that would mean that QALYs should not be implemented. And said that the Centers for Medicare and Medicaid Services should not implement any kind of model that includes the use of QALYs, including models that rely on prices from other countries. I think we've touched a bit on that many other countries use QALYs, not all of them, but a lot of them. And NCD recommended that CMS not implement any model that used prices or models from those other countries. Oh, and you asked about CCD too. So the Consortium for Citizens with Disabilities has been on the record for a long time opposing the use of QALYs. I think it gets the most attention in prescription drugs, but we are opposed to the use of QALYs anywhere in healthcare, and I bet would be opposed to its use in other human services as well.
It's interesting that you say that because, if you look at the history of the QALY, and I think this is something that a lot of folks don't realize, but when we go back to 1992 with the QALY as it was used in Oregon, it was actually more related to services than it was to prescription drugs. So that's a very good point. And so Kelly, we were able to play a little bit of a clip from an earlier interview that you did, but we recognize that you're such a great leader for the disability community and driving policy issues that impact independent living and uphold the national commitment to ensuring that people live in the most unrestricted settings possible. I hope something maybe you could talk a little bit more about the resolution and how this issue has kind of percolated to being such a priority for the disability community.
Yeah, sure. And I've been on, I watched the thing, and I saw the clip you played. I was actually going to kind of talk about what the resolution said, but you already the video already covered that, so I won't do that again. But it's clear from what everybody's already said up to this point. I mean, people with disabilities we are discriminated against in healthcare every day. I mean, we're doing a lot of work right now around making sure that provider offices are accessible, because they in fact aren't. So I go in and get get an annual exam. I don't get the same exam everybody else does because the exam table isn't even accessible. So I don't get cancer screening. I don't get any of that stuff that most men at my age would get. Never get weighed. I mean, discrimination in healthcare is really from beginning to end, and this is a really good example of it. And everybody's already talked about how it affects the decisions and how it affects the lives of folks. And so NICL has a resolution process that we use at our annual conference. And so that's the one opportunity that our membership actually has to drive our policy at NICL. And that's when people actually get to have a say in policies that NICL is going to work on. And so this is a once a year kind of a thing. And this last year, the resolution that we got was drafted by Not Dead Yet and the Autistic Self-Advocacy Network. But from what I can tell, it was actually submitted by Not Dead Yet because Diane Coleman is actually a member of NICL. And you have to be a member in order to do one of these resolutions. But I think the resolution is pretty clear about how it points out that QALYs are, just from what was just said, just the fact that they value a disabled life less than other lives, and that's discriminatory right off the bat. So what the resolution really says is that, and directs NICL to do, is really do a number of things that are action items to oppose the use of QALYs, and that includes legislation if necessary. I think the resolution actually talks about working on legislation that helps eliminate this. And so I was interested in the fact that there's already legislation out there that does it. The NCD report shows how discriminatory this whole process is too. And so I really think that thing around the legislative piece was really kind of interesting for me to read it, because I read the resolution again, and that's kind of interesting given the fact there's already legislation there, but maybe it needs to be expanded or tightened up or something. Maybe that's what they were thinking about. But you know, they referenced the NCD report in the resolution as well, and so, and 504 and the rehabilitation. There's a number of laws that affect this. So anyway, I'll stop there but I think the last, just to sum up, I think that this resolution really does direct NICL to do certain things, and because it was passed by the membership, I think you saw me say in the clip, unanimously, that really is pretty sound direction to NICL policy and leadership, or staff and leadership around what it is that we're going to be doing around this issue.
That's great. That's great. And I think you're absolutely right about, you know, in the context of the legislation, because it's confined to Medicare, it sounds like there's just a lot of concern that despite the ban on use of QALYs within the Medicare program, there are still ways to get around it with the Innovation Center, doing demonstrations and through Medicaid programs. And so that's going to be a really important area of work for us next year. Thank you, Kelly. I'm going to throw this question out to the group at large, because I do want to connect the dots a little bit. You've probably noticed that a lot of PIPC's advocacy has been also focused on the reference to other countries that use the quality adjusted life year, and which has been proposed for being imported to the United States through this, most recently through this most favored nation interim final rule that was put out by the administration. And so I was hoping that everyone on our panel could speak a little bit to the connection between the QALY and how it's used internationally, and the threat of it being then brought here to the United States. And maybe you have experiences with your international counterparts in other countries, but would love to hear a little bit more from all of you about that. And Rachel, if maybe you could go first.
Sure, yeah. I think we should definitely talk about what's happening in other countries. I do want to start, before we do, to talk just briefly about what's happening in the United States, because I think it's important when you start talking about international contexts to start off saying, we know the medications access in the United States is not okay. I have a job because medications access in the United States is not okay. Cost sharing is very, very high. You might have to go through step therapy, prior authorization, more utilization management. And that's because of the way that we have to address drug prices in the United States. The system is, an insurance company says, give me a lower price or your drug is not covered, or give me a lower price or you're going to go through step therapy, or give me a lower price or your patient's going to hit with paperwork delays every year or 6 months. These things happen now, and those of us that advocate for prescription drug access are involved in trying to fight against them and trying to make sure that, people talk about we've got to lower prescription drug prices, but if we do it in such a way that means you don't actually access the drug, that is not helpful to a person who needs that prescription medication. So when we move to talking about how QALYs are used in other countries, I think we don't want to take that same logic and apply it in an even worse way, in a way that's even more discriminatory against people with disabilities, and further doesn't actually improve access. It improves ways to limit access. So some of the things that we've seen, the National Council on Disability talked a lot about the United Kingdom, about access to Alzheimer's treatments, cystic fibrosis medications. And I don't know about you, but I've seen a lot of GoFundMes on the internet, and a lot of them are from the United States of people saying, "Oh, I have medical debt." But if you look, a lot of them are from the United Kingdom, from people saying, "My treatment isn't covered, and I am out of luck." So they're raising money, and you wouldn't think this should happen in a system that theoretically is supposed to provide access to everything, but it doesn't. And part of that is because of their use of QALYs. I'll say we have another example from New Zealand of decisions to switch which epilepsy medications are covered. And here we call this non-medical switching, meaning you are switched from one medication to the other, not because your doctor thinks this works better for you or you think it works better for you, but because an insurance company does. There, it's the decisions being made by the government for a QALY reason. Here, it's made by insurance companies for cost reasons. Again, that's something that we're really involved in fighting and trying to teach insurance companies that that's actually not a way to improve epilepsy care. What that causes is breakthrough seizures. It causes hospitalizations. It really disrupts people's lives. And we don't want to further adopt models that make that even worse. So that's what I've got on other countries. I definitely want to hear what other folks have to say.
Thank you. Yeah, it's interesting what you say, because I know just from Tony's personal experience, he often talks about a non-medical switching issue that happened to him personally with his epilepsy, and it was a very scary moment for him and with his condition. So I appreciate that as an example that makes a lot of sense. Kelly, I wondered if you wanted to share a little bit on this issue as well.
Yeah, sure. Well, kind of like I mentioned before, we already have plenty of discrimination in the healthcare system in the United States. We've seen what's happened with COVID in other countries like Italy, and the restrictions to ventilators, and we've actually seen standards of care put in place here where if you go into the hospital with your own ventilator, they'll take it away from you and give it to somebody else if they don't think your life's worth saving. So they can actually take your ventilator here away from you here in this country. And then, as I talked about before, I don't even get the same exam that others get when I go for an annual checkup. And somebody said to me, well, is there evidence that shows that not getting cancer screening for people with disabilities is a bad thing? And I was like, well, if there's evidence that shows it's a bad thing for the general population, then maybe it's not good for anybody. If we don't have evidence showing that if they don't get screened, of course it's a good thing. So I thought that was a really weird question. But I think that goes to show the kind of thinking that people have around people with disabilities. Somehow it's different for us. And I think we've got laws like that we talked about just a little while ago about the ADA, 504, and others in this country, but those don't exist in other countries. Some of them have put in place broad protections like the ADA in other countries, but they don't really have the same level of protection that we do, and they're not enforced the same. So I just really think it's not something that we want to further import into this country. Like I kind of mentioned, we've already got plenty of discrimination in the healthcare system here. In fact, one of my colleagues and I was just talking about that this morning, even around pain medication, right? So there's people that have chronic ongoing pain, and now because of the opioid crisis, it's not a system that takes us individually and looks at whether we need pain medication and whether we can manage it on an ongoing basis, because lots of us have for years and decades. But it's this broad policy now. So you can't get more than 7 days worth without seeing your doctor. You have to go see him in person. It's put all these barriers up for people with chronic pain to actually get access to pain medications. And pain medications were developed for a reason. Wasn't like they were just developed for no reason at all. So it really, there's a lot of discrimination around, like Rachel was saying about even epilepsy medications. As a lot of you know, my wife had epilepsy, and we went through a lot of that kind of discrimination around drug formularies and what they will and won't cover, and what kind of medications you can and can't take and get paid for. So anyway, yeah, I don't think we need to be importing stuff into this country. We got plenty of the discrimination here already. The one other thing I will just mention is the Michael Hicks case in Texas, as really kind of a startling example where African-American paraplegic guy was denied COVID-19 care, and they decided to end his life against his wife's will, by the way. And we and a number of other organizations, including AAPD and others, actually filed a complaint with OCR on it. And we, with HHS OCR, which is the same organization or agency that took some of these standards of care and got resolutions in states. But We heard that they told us they got the complaint, but that was the end of it. We have not heard anything since. So, and we're complaining about the fact that it was because of his disability and it was because of his color that he was denied the care. And actually life-saving stuff was actually removed, so he was actually killed. So anyway, I've spoken long enough probably.
No, that was it was a startling example. I remember it really rattled, I know, Tony as well, that story did. Dr. Buckland, is there anything that you would like to share on this issue?
Your question reminded me that the past is a foreign country and they do things differently there. We really need to reimagine our healthcare system. The legacy system was built during a period of segregation and inequality in this country. And not just for African Americans, but there was a devaluation of human life that continues. If you listen to the COVID discussions these days, you have elected officials who say the preservation of our economy is more important than the conservation of life. And that runs throughout our history and society, and it impacts our healthcare system, so that depending on who you are when you come into the healthcare system, and it's not just the quality metrics that you speak of. African Americans come into the healthcare system. I can tell you of clinical trials, protocols that restricted African Americans and Hispanics from participation in them. We all remember Tuskegee. And so the legacy system, its foundation is its valuing finances over human life. And we've come to a place here where we're able to innovate and really regenerate ourselves in ways in which past generations could not. Unlike the animal kingdom, where regeneration for them is, if their biology permits it, it happens almost without their control. What our biology allows us to do is to think through the problem, to collaborate together, to find solutions for illnesses that plague us. Look at hepatitis C, we've got a cure. HIV, we turned it into a chronic disease. And so those who think that by putting the brakes on innovation, by coming up with these bizarre models that are just home-cooked stuff that makes no sense at all, and they do it knowing full well that people are going to die, that people are going to go to the hospital, that people are going to become disabled. But they don't report that in their model. There's no place in their model that says, if you deny this patient access to hepatitis C medication, they are going to die. And we've got 14,000 people who die every year from hepatitis C, and we have a cure. So it is not just the disability community that is suffering from this legacy system. I would argue that the whole country is suffering because we are not putting our minds to work to cure the diseases and illnesses that trouble us. And we cannot go through the 21st century like this. We cannot come out of the 21st century knowing full well that we have the capabilities even to edit at the genomic level of these diseases. And so we need a new healthcare system. We need to reimagine CMS. This is not a conversation about we don't like quality. We don't like CMS. I'm telling you that it's an old-fashioned institution. It is just Hicks renamed, and it's time that we have, and we all need to come together on this. Patient advocacy has to be about patient first. It has to be about making sure that everyone who comes into our healthcare system, their risk is reduced. That is the job of the healthcare system, period, full stop. And you do not get to discriminate against anybody at any time coming into the healthcare system. And I think we all have to fight for that. And we cannot be bullied by those who want to ration and talk about money. We have to find ways to make sure that all of us get access to the healthcare that we need. That's our job.
Well, thank you. I could not agree more, and I think that that's hopefully, that's something we can all work on together next year. Andrew Sperling, did you have anything that you wanted to share on this topic of international pricing systems?
No, and I'm just noticing the time. I'm curious if there are audience questions or comments, because we've been talking for a while.
I know. So we are going to, probably have to end pretty soon. I know that we got started a little bit late, for which I apologize. But do want to just maybe, in terms of the panel questions from the Q&A, it sounds like there's a lot of interest in understanding what do you want out of next year? What would you say to policymakers should be a priority walking into next year? Knowing that we're all, I think, on the same page about wanting a more patient-centered direction. And so maybe I'll start with you, Dr. Puckgren. Can you maybe give us an idea of where you want to see us go next year, and maybe keep it short, and we'll do that as our final Q&A.
I would love to see the patient advocacy community come together to work on a new healthcare system for the country. I think patient advocates have to be the catalyst of change, and they need to come together to reimagine this system.
Great. Andrew.
Well, I'm not really optimistic about a lot getting done next year. I think, depending on how these two Georgia Senate races go, we're either going to have a 52-48 Senate or a 50-50 Senate, a smaller majority for the Democrats in the House, and a new administration. So I'm actually, not betting is probably the wrong term, but I think many of the pundits out there, people that follow this closely, are predicting with a closely divided Congress taking on healthcare in a major way for coverage expansion or other types of things probably isn't going to be there. And I think we're going to see the Biden administration in the first 6 months of 2021 really focused on potentially likely undoing some of the threats and some of the changes that were made administratively to the Affordable Care Act over the last 3.5 years. And I don't look for Congress to really be doing a lot in terms of major healthcare legislation in 2021. So I think it's going to be incumbent on us as patient advocacy groups to work with the administration around some of those issues around the ACA and making sure that, there are voices inside the Democratic Party that, I mentioned earlier that the House bill, the House ACA bill, way back in 2009 and 2010, had some damaging things in there in terms of what they wanted a PCORI-like entity to do. So I think we're going to keep an eye on that and make sure that we provide input to the Biden administration not to go there.
Rachel.
Yeah, I think I agree with Andrew that we're probably not going to do any big giant things, but I think in small ways we can make sure that Congress and the administration keep their eye on the ball, which is actually and meaningfully improving access and improving real people's lives, and not, bigger models and ideas of how you're going to, rein in drug prices, but like, okay, what does that actually mean when a person goes to the pharmacy counter to pick up a med that they need? Focusing on it.
Got it. And Kelly, we're going to end with you, Kelly.
Oh no, I have the last word. Well, I actually think we may see some big changes in healthcare, but just expanding coverage isn't going to address any of the things that we've talked about today. Just because more people get covered doesn't really change anything that we've talked about. So what I really hope to see this coming year is enforcement of the laws that are already there, and some reversals of some of the policies that's been put in place, like Andrew talked about. If we could reverse some of the awful things that have happened over the past 4 years regarding healthcare, and then including most favored nation kinds of stuff, and then actually start enforcing laws to address racism and ableism, and that would be a great thing as far as I'm concerned.
I think Tony would agree with you. Thank you. Well, this was a really exciting panel discussion. I appreciate the input of everyone, reacting to some of the information that we had at the beginning. I just want to say thank you to everybody who viewed today. I think it was important to us to make sure that we provided some of that background information about Pixi, took advantage of this opportunity being virtual to reach a lot of you who may not live in the Beltway. Typically, we've done this forum in Washington, D.C., and it's been largely attended by people who are sort of in our orbit in this D.C. area. But hopefully we had an opportunity today to help others outside of this region too, to understand the history that's led to the creation of the Patient-Centered Outcomes Research Institute, and a lot of the really big issues that we're going to be keeping an eye on next year as we go into a new Congress and a new administration. So thank you to everybody who joined us today. And if you have any questions, please feel free to reach out to us. If you got the invitation to this, then you have our emails. So we're happy to answer questions offline. And again, thanks to everybody for joining. Thank you.